evening, everybody. Not good enough. Good evening, everybody. Thank you. I like hearing that. Way to go. Way to go. Thank you. So for those that don't know me, my name is Stuart Schlossman, and I want to welcome you to this event, being our second annual Memorial Neuroscience and MS Views and News partnered multiple sclerosis learning program. So I want to thank you all for being here. I'm sure that they appreciate it as well. All right, this event is solely sponsored tonight by Memorial Neuroscience, okay? And they're doing this because they want you to learn what it is that they have to offer the MS community. They have things that, if you're seeing other neurologists or general neurologists or otherwise, if you're living out of this county, living in another community, this is something that you might find interesting, whether it be with tonight's speakers or in general, everything that they have to offer from this comprehensive MS Center. I said that wrong. It's supposed to be comprehensive in the quotes, not the quotes before comprehensive. So our last speaker of the day is a name that many have come to know in the last couple of years, and many will probably be seeing in the next few years as well. His name is Dr. Adnan Subei, and he has joined Memorial since 2015. He's established the MS Center at Memorial East, and I believe that they are now doing this for Memorial West. He's trained in neuroimmunology at the Cleveland Clinic and neuro-ophthalmology at the Michigan State University. I do not know where he is right now because it is so bright up here that I'm going to ask him to come on down. If he wants, he could, oh, there he is. You could come running up if you want. But thank you. Let's give him a round of applause. Thank you. Thank you.
All right, good evening, everyone. So this is a different topic because when Stuart said that we want to do this program again this year, I was trying to think of something different, and I really designed these slides specifically for tonight. I've not done this presentation before. It's a topic that I really enjoy, which is visual problems and multiple sclerosis. So to start off, I'm just going to let you know that disclosures. So as a Memorial employee, I do not speak or have any financial relations with any drug company. And not that we will be discussing any specific drugs in this topic. So MS, most of you or all of you should know what MS is. It's an autoimmune disorder or an inflammatory disorder that affects the brain and spinal cord. And of course, an extension of the brain is the optic nerves. So you can see the lesions that you would see on an MRI, lesions in the spinal cord, and then lesions in the optic nerve. So that's just to show you what these changes would look like on an MRI. So the first part of my talk is focusing on the anatomy of the visual system. When we think of vision, we split them into two parts. So there's the afferent, which is input. Then there's the efferent, which is output. So if you're a technical person or you deal with electronics, then you know there's ins and outs that you have to plug in with wires. If not so, then maybe this will help you visualize this. So the first part of this is to talk about the afferent pathway. Raise it up. Okay. All right, so the eye is our camera. So each of us could think of the eye as a camera. And that's what that's what we perceive with vision. And then we also have mechanics that help us move the camera. So this is what the eye looks like. It's a side view. If you sort of cut out the bone from the side, and so you'll see the eyeball, you'll see the muscles attached to the globe, and you'll also see the optic nerve and then other nerves that are within the orbit. And if we make a cut through the eye, then this will show you further the anatomy of the eye. So let's talk about this. We have the cornea, which is the front part of the eye. Behind the cornea, you will see the iris, and that's the colored part of the eye. And then right in the center is a pupil, which is basically a hole. So that's where the light comes in. Behind that, there's a lens. The lens helps us focus light into the back part of the eye. And then this yellow part is called the retina. The retina is the layer that perceives the vision and then it sends the signal to the rest of the brain. So, and then you have supportive layers and then the optic nerve, and that goes backwards towards the brain. So the retina is comprised of millions and millions of cells. The furthest layer in the back, these are the cells that process the light. They're rods and cones. The rods perceive black and white. The cones perceive color. And this is the layer back here in yellow. And then these rods and cones will then join with other cells, and then the signal goes back to the front or a little anterior, and then you'll form the fibers that will form the optic nerve. So the signal will come front to back, and then a little bit further front, and then back again through the optic nerve. So, and just a fun fact, so the retina contains 120 million rods and 6 million cones. The cones that are involved with color are focused mostly in the center part of the vision, because that's the part where the light tends to focus, where we're able to see the best, the richest perception is there. And then the rods are further out in the periphery, because we just need to know if something is there, but we don't need to know the details of what's out there. So an analogy to what a camera looks like, same thing. So you have light coming in that's then focused onto the film of the camera. And that's exactly what happens in the eye itself. So light comes in, and then it comes onto the retina. So coming back to this, again, the same analogy. So light coming in, and then it hits straight through the retina. So it's really a fascinating structure. More of a visual. Okay. All right, so this is what the retina looks like. So when we look in the back of the eye and you're wondering, why does he put this light on my eye? That's exactly what I'm looking at. So you have the optic nerve, which is this yellow circle. And then out of the optic nerve come blood vessels. And they fan out to the different parts of the retina to feed the retina. The retina is this entire orange structure. And right in the center, do you see this gray, darker area? So that's the macula. That's the center part of the vision. That's where most of the focusing is and where the visual processing is going to be. So if you go to an eye doctor, then you notice that they use this machine called a slit lamp. And it helps focus the light on the different layers of the eye. So they start first by looking at the cornea. So when they turn the light on, then they can see the cornea, they can see the iris, and then they can even put a lens in front of it so that they're able to focus on the optic nerve deep inside. This is what the visual pathway looks behind the eye. So once we're done with the eye and the signal goes back to the optic nerve, so you'll see the eyeball right here, then the optic nerve heads backwards towards the brain, and then in the thalamus, or underneath the thalamus, is when then the fibers are going to start splitting into back to the occipital lobe. And then some fibers will cross over to the other side, and some fibers will cross to the other side. The reason for this is that, similar to how you think about the nervous system works, in that if patients who think about stroke symptoms, if they have weakness on the left side, that means coming from the right side of the brain. Well, the same thing is for vision. So everything on the right half of my visual field is processed in the left side of the brain. And everything from the left side of my visual field is processed in the right side of the brain. So these fibers will kind of mix, and each fiber will go to that part of the brain. Okay, so we talked about anatomy. So now it's time to talk about some common afferent problems that we see in MS. So I'm going to throw this question out there. What is the most common problem that we see in MS? Yes, optic neuritis. So what is optic neuritis? So optic neuritis is inflammation, or when MS activity affects the optic nerves. So if this is what any of us would see, if we're looking out, if we have optic neuritis, then we may experience something like this. So typically it may affect the center part of the vision. Sometimes it's not the center, it's out in the periphery. It's very random in terms of what the visual deficit looks like in optic neuritis. Sometimes it's very mild or subtle, and sometimes it's pretty profound where you can only perceive light or shadows. Usually the inflammation happens behind the eye. why is this important to stress is because then if you look inside the eye, you don't see a problem. And that's why most patients who have optic neuritis, they go to the eye doctor and they said, nope, everything looks good. That's because the inflammation is behind the eye, 65%. So most people will have it behind. Rarely you can have it in the front part of the eye. So this is what the nerve looks like when someone looks in the back. And this looks normal. So you can see the disc is nice and sharp. You could clearly tell there's a circle, and then you have the blood vessels coming out. There's nothing wrong with this. If the inflammation is in the front part of the eye, we call it papillitis. It's just, this is what it looks like. So you could see that that nerve is inflamed. You don't see that sharp, crisp border, and it's all blurry from the swelling in the nerve. All right, so usually we test vision with an eye chart, and then you'll notice that whatever, patients can usually see the 20/20, so then the vision may worsen, and then they, may be reading 20/30, 20/40, 20/50, sometimes 2100, or even worse. So, but this is the first test that we do to assess the vision. So next comes color, because if you acquire vision loss, then you lose color. If you're born with vision loss, if you're born with a lazy eye, then you retain color, it's preserved. But if this is something that happens later on in life, then you lose color. So we always test the acuity with color. And then we test your visual field. The visual field is how far out someone is able to see. And this is an electronic visual field that we're able to capture. And you can see here that this is a normal visual field where the black part, that's the optic nerve. That's not a problem. Our optic nerve doesn't process light, so it's dark. And then the rest of the retina processes light, so and then the other eye has some black spots because that's the inflammation from the optic nerve, so it doesn't process. So we put these together. So when we see a problem with the reading, losing color, visual field, now I'm slowly making a case for optic neuritis. This is the machine that we use to test the visual field. So if some of you have had this, it's the most boring test in the world. It takes about 7 to 15 minutes to do each eye. You have to put your face in the bowl, and then we flash a light, you click, you flash a light, you click. If you doze off or if you don't pay attention, then it has to repeat that target until it makes sure that you get it. And then if you don't, then it marks it off as a black spot. So it's a lengthy test, but in the end, the information is useful. And we also look at the reliability, whether you're looking at the target or if you're looking all around, or if you're just a happy clicker and you're just clicking, then the machine picks up on all of that. So then I either say the report is reliable, or I say, no, I can't make any conclusions out of this. So then, on a side note, we make an interpretation of the visual field in our records. So, but as someone who's interested in eye problems, I always like to look at the visual fields myself, because sometimes the interpretation doesn't always relate. If I may look at a picture and I may think one thing, and then someone else may look at the picture and think of another thing. This is similar to MRI, how we like to look at our own pictures. So this is just to show you how, okay, so when you first have optic neuritis, the optic nerve looks okay, there's no problem because the inflammation is behind the eye. And if you measure the thickness of the optic nerve, and we have machines now to do this, the machine is called OCT. So that everything is in green. And then it may change that at that time, or it may change usually over 3 months, that you start to notice that you see the results of the damage. And so then there's thinning of the nerve. The optic nerve doesn't look as healthy, and it turns red. And if you look at the optic nerve, it looks pale, it looks whitish instead of that orange color. So usually when we look at nerves, I can also tell if someone has had optic neuritis before, or or maybe they've never had optic neuritis, but then we see changes to the optic nerve. That's because some patients can develop slow decline in their visual system, even if they've not had optic neuritis before. Okay, so I'm going to show here an example of one of my patients who has had optic neuritis. So this is BB. So they develop painful vision loss in the left eye that every time that person looks around, it hurts. So that story sounds like optic neuritis. It started one day, it lasted an entire day, the pain. By the next day, it became blurry. By the third day, can't see much out of that eye. So when you test it, then it's 20/40 in the left eye and 20/20. What these numbers mean is that what I am able to see at 20 feet, other people are able to see at 20 feet. So whereas the 20/40 is what people can see at 20 feet, it's the other way around. What people can see at 40 feet, I need to come closer at 20 feet to be able to read it. So that's how the measurement is. Okay, so you know, instead of the line down here, that person is reading up here. And then color, instead of being able to read 10 color plates, they're only able to read 1 color plate. And then this is what the visual field looks like. This is an actual visual field that we did in the office. And then you could tell that, you know, right in the center, that person is seeing pretty good. But out in the periphery, they're not having good vision. So, and remember, this is normal because the optic nerve is not supposed to see. Okay, so this is what the visual field looks like. And then I took a video of this and it wasn't that great, so sorry. This is a picture just to show you. I'm going to try to show you. So you shine the light in this eye, and then you go and shine the light in the other eye, and it's smaller. You go back to this eye, it's bigger. You go back to this, sorry, so this is bigger, this is smaller. So that eye is not perceiving light the same way that the other eye. So that's why we swing the flashlight from one eye to another. So you could tell even, you know, there's that piece. And then if you do the MRI, then you see the inflammation of the optic nerve, whereas this nerve doesn't show any inflammation, this nerve is inflamed. So that diagnoses you with optic neuritis. So, and sure enough here, this is another picture. This is, if you want to picture that person looking at us. So this optic nerve is showing up, this optic nerve doesn't. So this is inflamed. And that's the contrast part of the MRI. So then you diagnose this person with optic neuritis, it's a relapse, you give them steroids to try to improve the speed of their recovery and hopefully get them back to seeing 20/20. Depending on the severity of the optic neuritis, some patients make a full recovery, some patients don't. I've had patients who have had optic neuritis in one eye, it got better, back to 20/20. Then shortly after, they've had optic neuritis in the other eye, and that eye did not get better. And so it can happen sometimes. And especially if you develop recurrence of the optic neuritis in the same eye, then your recovery chances get smaller. Here's an interesting example of not necessarily optic neuritis. So let me show you what this person has. So this is someone who started to notice vision changes in both eyes. So this is the left eye. This black circle is their optic nerve, so that's normal. But then right here, there's another darkness. And then this right eye has also some darkness right here. So both eyes are having problems. Then over time, this is a month later, this got worse where they're missing the entire half, almost the entire half of each eye. So as soon as you look at this, as a neurologist, I could tell you that this is not optic nerve. Optic nerves don't do this because the optic nerve would not know to distinguish this half like this, to split everything in half. So then where could the problem be if it's not in the optic nerves? So then take back, thinking about the anatomy of the visual pathway and where these fibers run. So then everything that you see on this side is processed back here. Everything you see on this side is processed back here. And actually, this is the point where these fibers are starting to split. So this person has a lesion right in that area where these fibers have split. So it's a brain problem that's causing vision problems. So that's a delicate lesion that happened just in the right location or in the wrong location that caused that person to lose half of their vision. So it's a relapse also. It's just inflammation happened to happen in a different location. So you treat that person, and then shortly after, this is what their visual field was. They got better, and that resolved over time. So this is another type of relapse that's not necessarily optic neuritis. Now, so Okay, so now we're going to switch gears. So, we talked about the camera part of the eye, seeing everything and processing all that. But then what about the other part, the efferent, which is, okay, how do you move the eye around? And then what problems with eye movements can you have? So this is the main location for the efferent pathway. So it's in the brain stem, the bottom part of the brain, and the cerebellum. This part of the brain will process eye movements, along with other things, but we're talking about vision. So the main 3 nerves, so we have, in our head, we have 12 nerves. And there are 3 main nerves that deal with eye movements. So, and those are the 3rd, the 4th, and the 6th. I won't bore you with their names. So the 3rd nerve is up here in the midbrain, so is the 4th nerve right underneath, and then the 6th nerve is down here. So where that circle is. And then from the nucleus, the nerve will come out, and then it'll exit the brainstem out to go to the muscles. So these are what the muscles look like. So we have superior rectus muscles, superior oblique muscles. We have inferior rectus muscles, inferior oblique muscles. We have lateral rectus here, and then medial rectus here. Okay? So the 6th nerve is the nerve that will move our eye out. So whenever we look off to the side, that's the 6th nerve that's doing this. The 4th nerve actually works on the muscle that works like a pulley. So it'll end up moving the eye down and out. And then the 3rd nerve does everything else. So all the other muscles, including the constriction of the pupil. So it'll make the pupil smaller. Okay, so what are some of the common problems that patients with efferent problems will have? So have you had double vision or diplopia? So diplopia is just a fancy word for double vision. And if this is what any person would see, this is what someone with double vision would see. So the images are not exactly aligned right, okay? And it's not necessarily side by side. It could be side by side, up on top, or it could be off at an angle. So in any one of those directions, patients can have double vision. But you have to think of it this way. Each eye is normal. So the right eye sees fine, and the left eye sees fine. But it's those 2 images, they just don't happen to overlap. So that's the problem. So going back to the eye movements and trying to look at this, I'm going to show you some patients who have eye movement problems, and then we'll kind of walk through this. So yeah, we're going to have to play the video. Okay, so we're going to play this a few times, so don't worry if you missed it the first time. This is someone looking to the left, and then now they're going to look to the right. And then now they're going to look up, and then they're going to look down. All right, so before we, okay, play it again. Looking to the left, looking to the right, up, down. Do you guys see a problem? Okay, hold on. So this person actually didn't tell me that they were having double vision problems. As soon as I saw their eye movements, then I asked them about it, and they were like, oh yeah. So they actually have difficulty looking out either direction, right or left. So play the video again, and then watch how each eye will flutter or have nystagmus. Now he's looking to the left. Look at that eye beating. And then look at the right, beating. Okay? So if you want to think of nystagmus, it's like the eye is trying to pull itself off to the side, and it can't. So it keeps trying to do this. So, all right, this is another picture to show you, a video. Go ahead. So you cover one eye, and they're focusing on a target. You cover the other eye, they're still focusing. and we go back and forth from one eye to the other. What do you notice? Let's play it again. Oh, wait. It's still going. Yeah, I guess. All right, that's fine. All right, play the video again. He's focusing on the target. What happens? What happens? Okay, so let me try to explain this. Pause the video. Okay. All right, so this person cannot look out in either direction. So the eyes are sort of like this. So if I want to look at this target, and so I'm using this eye, if I want to shift to that eye, it shifts like this, and then it shifts back, and then it shifts back. So every time I cover an eye, each eye is trying to look at the target. So you could tell there's a misalignment between the two eyes. Because if I was at a normal person, no matter what eye you cover, they're not moving because each eye is on target. So then you could notice this by shifting back and forth between the eyes, and then you could tell that there is a shift, and you can measure that degree of shift. So when I looked it up, it was 10 diopters. So when I put the prism with 10 diopters, now look at what happens. The eyes don't shift. So then you know that, okay, so this is the degree that someone has, or this is the diagnosis that they have, and then management depends on that person. So in this situation, because it's affecting both eyes, which means that if the person is looking straight ahead, they're probably not going to have as much double vision as if they're looking off to either side. So they just need to learn to compensate is by turning the head, because they can't rely on eye movements alone. Okay? Sure enough, if you do the MRI of the brain, then you see that there's MS activity in the area that controls both sick nerves. So that fits with what I'm seeing on the exam. And that's where the nucleus would be. So that red part, so that's exactly where there's white on the MRI. All right, here's another patient. Let's play that video. Looks to the right, looks to the left, right, left, right, left. Whoever gets this right, Stuart's going to give him a prize. Is this normal? What's wrong? Who said slow? Yes, thank you. All right, play the video again. Look right here. Wait. Look right here. Looks slow. Right, left takes a while. So this is what we call an internuclear ophthalmoplegia. Fancy word. It just basically means that the connection between the two nerves, the 6 and the 3, it's not connecting right. So that's where the problem is, and that's why some patients, when it's very mild, then it's just slow for it to look in. When it's pretty severe, then they can't go past the center. And so one eye will look that direction, the other eye will stop right here. It can't go further. But when it's very mild or subtle, then it's just very slow as it's going. No, it's just the connection is it's not that strong, so it takes it a while for it to be able to pull the eye. So, and this is where the lesion is in the brain that's causing that misconnection between the two. So, and it's just, this is a cartoon just to show you that it's the connection between the 3rd nerve up here and the 6th nerve down here. So that wire is hit from the MS lesion. All right, so here's, I think this is the last patient that I have. So, What do you guys think? So this video is not slow. So you could tell that these eye movements are very slow. I'm telling that person to look in this direction and look at how long it takes. Let's play that video again. So look at how long it takes for that person to look. Very choppy eye movements. It's a struggle to look in that direction, and then a struggle to look in the opposite direction. So, and then the other thing to pay attention to is the head tilt. So this is in the wiring of the brain that controls the balance of how the eyes and our vestibular system. So patients will develop a head tilt and they might have some eye movement problems. So you could tell just by looking at that back part of the brain that there's a lot of shrinkage, there's atrophy. This brain doesn't look entirely healthy, and this is from having multiple lesions in that part of the brain over time. Then there's shrinkage and atrophy. So then it's not a specific part of the brain that does this, but it's the overall connections that are affected. And that usually is from the cerebellum, the back part of the brain, up to the brainstem. Okay, so now what if I had blurred vision? What do we do? So you got to figure out a few things. So it doesn't help me when someone comes in and says, I have blurred vision. So we need to do some investigation. First of all is, which eye? And then the usual response is, oh, I know, it's my right eye. No, you don't know. Have you tried to investigate this? No, because I know it's right here, I can feel it. Well, no, you have to cover one eye. Is it there? Yes. You cover the other eye. Is it there? Yes. Then, well, it's not the right eye. Or the other way around. Is it there? No. Is it there? No. But with both eyes open, yes. So you got to investigate to figure out covering each eye, because then that helps us sort out, is this an afferent problem of receiving vision, or is it an efferent problem of moving eye movement? Okay? Is it constant, or is it intermittent? Does it come and go, or is it there all the time since it started? Because that's another that helps us sort things out. And then, when did it start? So, is this something that you've had for years, off and on, or is this something that just started, 2 days ago? So that also helps us. And then, is there any pain associated as well? So all of these will help us understand what kind of eye movement problems or eye vision seeing problems there are. Okay, so this next section is going to talk about things that are not necessarily related to MS, but you may experience. So, other conditions. There's something called presbyopia. So, unfortunately, every one of us, once we pass the age of 40, we will need reading glasses. And that's because our ability to focus on near objects is gone. The muscles stiffen, and we can't move that muscle in the eye. So everyone will need reading glasses. So most common patients who I see who are in their 40s and they start to say, I've been having blurred vision. And then I scratch my head and I'm like, yeah, I think I know what it is. So that's the most common condition. So, and on a side note, the pinhole effect. So when someone comes in, is not able to see, sometimes we test their vision and we put the pinhole to try to see if we can make their vision better. So if someone is, let's just say, reading a 20/40 line, and I put the pinhole and I could bring it down to 20/20, normal. So then that tells me that it's not a true vision or MS-related problem, because I'm able to get that person to see 20/20. It basically means that it's a filtering problem. So if you kind of think about it, it's similar to when you're trying to see something at a distance and you can't see it that well. What do? You squint. Why? Because you're trying to focus all that light into the center part of the eye. And that's exactly what this pinhole does. So every time I put it on a patient, they say, how is this supposed to make me better? It's a small hole. And then they look at it like, oh God, I can read it. So this is why. Okay? All right. So cataracts. Cataracts are also common. It's probably maybe the most common ocular condition in older age. And a cataract is basically just a dirty window. That's what it is. It's nothing pathological. It's nothing wrong with the eye itself. It's that the lens of the eye will sort of frost over time and get dirty. So instead of a nice black pupil, you'll see a change in color. So that's usually what we see when we shine the light. To patients, mostly they notice glare at night with lights. So that usually tells us that maybe it's the cataract that's acting up. So unless it's pretty severe, you don't notice problems in the daytime. So macular degeneration is also common. So instead of seeing nice square boxes, so you may get metamorphopsia or changes in the way that you perceive vision, and that's because of the degenerative problem in the retina. That has nothing to do with multiple sclerosis, so that may also happen. I'm quickly going to talk about this, macular edema, just because sometimes you can develop swelling behind the retina. And if you see here on the scan, this is the retina, and you've got some fluid underneath. The only reason why I bring this up is because this is something that we look for in patients who elect to go on a medication called fingolimod or Gilenya. So in the first 3 months that we have to screen them for this to make sure that they don't happen. And I can tell you that I've never seen it on a patient with Gilenya, so it's not that common. So, okay, to summarize, and I've got 13 seconds. Optic neuritis is the most common problem in MS, okay? So we have to sort out when we see patients with eye movement problems or vision problems, is it eye movement or is it visual input, optic neuritis or brain problem? So we have to test each eye separately to figure out, okay, what is each eye seeing, and then put the eyes together, and what is the combination doing? And then there are some other non-neurological or non-neuro-ophthalmological conditions that can occur, which are not necessarily MS related. Thank you.
Yay, thank you, thank you. Before we take any questions, I just want to remind everybody that we gave you seminar evaluation forms at the beginning of the program. We do hope that everybody, even caregivers, fill out those forms, please, so that way we know that you were here, okay? So first up, who's got a question? I'm going to go there first because it's closer. And besides, you spoke a lot. No, I'm joking.
Again. So my first question is there any correlation between MS and an epiretinal membrane?
Not that we know.
And my second question is, can you use those pinhole glasses to read in lieu of reading glasses?
I'm probably not comfortable, but you can.
Okay, thank you.
Thank you.
Hi, in all the symptoms that you showed there of the people with MS, where does stigmatis fit in?
Astigmatism.
Stigmatis. It's the thing where the eyes get, yeah.
Nystagmus is just a word to refer to an abnormal eye movement. So instead of looking in one direction and being fixated there, there's a drift and then a correction. That's what nystagmus is. And that depends on the mechanics of where the problem is with the eye movement that we would see the nystagmus.
I understand that lesions on the brain can be reversed. Is that true? And then I go to my second part of my question.
Some, yes.
All right. Well, assuming they can, and we know that lesions in certain parts of the brain can cause optic neuritis. If the lesions go away, can the optic neuritis be reversed? Or once you have it, you're stuck with it?
Yeah, so some optic neuritis or optic neuropathies will improve, and then others won't. Usually, well, nowadays we're able to measure the thickness of the optic nerve, and we can tell the chances of recovery, because if you thin the nerve more than a certain number of microns, then that reversibility is less likely. The nerve is too damaged.
Thank you, doctor.
Did you go to ophthalmology first, then go into MS, or how did it happen?
I was actually interested in becoming an ophthalmologist first. And then after I did my year of neuro-ophthalmology, I decided to switch over.
Hi, I first presented with optic neuritis, and it cleared up right away, which was great. But occasionally I get this crazy stabbing pain. Is that anything to be concerned with? Is that just a flare or?
So sometimes, well, no, sometimes you can just have stabbing pain that's part of a pain syndrome, and it's not necessarily an optic neuritis. If you have pain only with no vision, and especially if something that's recurrent, you get it from time to time, and then it's less likely for it to be the optic neuritis. If you've had optic neuritis, you can have the symptoms come back. If you have a sickness like a UTI, flu, something, then your vision may worsen. Or if you're out in the heat, then your optic neuritis symptoms may come back.
For the jerky eye problem, is there any solution for that?
Sometimes yes and sometimes no. So it depends on not the movements that the last person that I've shown, no, but sometimes when patients have nystagmus that's continuous and is from the balance part, like a vertiginous, then we're able to suppress it with certain medications. So it all depends on the context of it. I could tell you that what I've shown are things that mostly we identify, not so much the patients do. So because once these symptoms show up, it happens for a few weeks and then the brain kind of is able to suppress it, but we're still able to see it. The only reason why this is so important or it's interesting, because it's completely, it's tied to the balance, and so it's critical in someone beyond vision. So it's also balance, coordination. So it links more than one system together. At the same time, it tells me that the MS is more severe than a typical person because the brainstem and cerebellum are critical parts of the brain. And so if someone's having lesions there, they probably need to be on different medications than what someone who has lesions elsewhere.
Hi, thank you for your information. 2 questions. You don't take Humana HMO?
Reverse it. Humana doesn't take us.
Okay, I understand. And my second question, forgive me if you've answered this, but if you've had severe optic neuritis, which my husband did, and he completely cured, 20/20 back and everything, what are the chances of him getting that again, or you don't know?
It can still happen. So
you just don't know, right?
It depends on when, and so...
no way to prevent it.
No, but we could, no way to prevent it. Well, yes, disease-modifying therapy. So the MS medications.
Oh, okay.
Yeah.
Yes, he's on that. Thank you.
So I have a question. What is that match-like feeling that I get in my left eye, like, daily?
Ouch, I can't answer personal questions.
Okay, that's true. So what is that match-like feeling that certain people get in their eye every day?
It could be a headache syndrome. You need to see Miriam.
Okay. And also, there are certain people that have said that during times of heat, especially when they're outside, that they get like this plastic-like look when they're looking out one or both of their eyes, okay, that looks like they're looking through plastic. And they notice that when they cool down, it gets better, but while they're out, it's...
So this is what we call Uthoff's phenomenon, which is the same concept that applies to any other problem with the nervous system. So if you heat someone temporarily, their deficits or their problems will show up, and then if you cool them down, then they get better. You could argue that if someone says, well, I've never had optic neuritis, but why does this happen in the heat? That's because maybe it's subclinical that you've never noticed it, but if I test it, I can find optic neuropathy, damage to the optic nerves, that then the signal will get weakened in the heat, and then it comes back.
Dr. Subei, I have a question regarding the double vision. Is that part of optic neuritis? And is that something you said you can see if someone has had it in the past, not necessarily that someone has it now?
Let me okay. So it's the same concept. It's inflammation and lesions, but instead of it happening in the optic nerves, it's happening in the brainstem or the cerebellum. That's the part that controls the eye movements. But it's the same concept, inflammation. Sometimes you can see residual effects from someone having it, and sometimes it only shows up in the acute phase and then it gets better and then you don't see it.
And also, if any of us are having, let's say, an exacerbation of our symptoms or a relapse per se. And we're having, you know, some of these examples that you show us, perhaps that person or those patients are feeling what I call, I don't know how to call it, I call it like a lazy or later effect. Like I can't help it but to say as if I'm moving my body or my head, my brain, but then my eye still, or my eye and my brain are still kind of like slow, 2 seconds behind, kind of.
It's only a matter of seconds. Questions.
I know.
So
I know people are probably feeling.
Hold on. I'm not going to answer your personal question, but that phenomenon, we get it from time to time of vision, you know, sort of lagging behind. That's what I showed you with the internuclear ophthalmoplegia. So that's the wiring doesn't come in. But I don't know if you have that or not, or someone.
Can a routine eye exam predict any of this?
Usually, this is not part of an exam that you would get seeing an optometrist.
Okay. It's the brain.
But at the same time, you would never get a prescription for glasses from an office of a neuro-ophthalmologist. So, you know, each person has their own field.
If one has had an internuclear ophthalmoplegia and has mostly recovered from it, it can return over time, correct? And if so, can you get to a point where you don't come back from it?
Unusual. Can happen.
If you had an undiagnosed optic neuritis in the past and then you got better, would an ophthalmologist be able to see it on an OCT years later? Still see the residual effects on the OCT, or would it appear normal?
So we've had patients who they've had optic neuritis before, but let's just say because their nerves are thicker than normal people or most people, so when they thinned out a little bit, but they're still within the normal range. But compared to the opposite eye, you can see it thinner. So you can sometimes see that difference between the eyes. Sometimes patients will say it, or that they have a history of optic neuritis. I don't see any signs of optic nerve damage, and then we just won't know. Maybe it's a subtle optic neuritis, or maybe it was never optic neuritis.
I want to thank you. This has been an excellent presentation. I didn't realize that I had optic neuritis about 10 years before I was diagnosed, until I saw that screen. And then it went away. And I have perfect vision. I need reading glasses because of age. But other than that, it's normal. But thank you so much.
You're welcome.
Thank you. Are there any other questions? No other questions? Thank you, Dr. Subei. And thank you to Memorial.
Thanks.
We want to thank everybody for coming here. We want to again thank Memorial Neuroscience for partnering with MS Views and News to do this program. And of course, I have to thank all of you, because we couldn't do this without you. Thank you.